Hello, everyone, and welcome back to Rarely Typical, a podcast where I am talking about living life with a chronic illness, finding hope, and living a life that is rarely typical. My name is Gerry Langan, and I'm so excited about today's podcast because I get both of my doctors on the same screen. So if you're watching, you're getting to see both of them right now. I am so excited to bring this episode to you guys because one of the biggest things about my care is collaborating doctors. And that is something that I know lots of patients don't get. And so I wanted to cover that today. So welcome, guys.
Thank you very much.
Great to be here.
I'm Dr. John Moss. I'm a pulmonologist in Jacksonville, Florida. I've been doing pulmonary hypertension for about the last 15 years, exclusively in clinic for the last 6 years. I see all different types of pulmonary hypertension, including PAH, whether that be idiopathic, whether that be related to connective tissue disease, interstitial lung disease, or chronic thromboembolic disease, PH. So that's my main clinical focus. I participate in various clinical research trials, as Gerry has participated in, and I'm glad to be here.
And I'm Dr. Peter Hountras. Great to be back. And I essentially do what John Moss does, but just several states away in Colorado.
So today we are going to be chatting about what it's like to have collaborating doctors. So I have been very fortunate. I've also been very unfortunate before, but that is a story for a different time. But today we are talking about collaborating doctors, and both of these doctors have had very big pieces of my story, and they are very big parts of my care, obviously, because they are my doctors. I see Dr. M regularly, probably once every 3 months right now. And Dr. H was my diagnosing doctor. And so I do find it to be very important that patients understand that they can have doctors that will collaborate and not just doctors that collaborate within their facility. So when I was in Alabama, I was seeing a team of doctors, and those doctors work together. And both H and M both have their own teams of doctors at their hospital, but that's not what I'm talking about. I'm talking about the fact that I was diagnosed at one hospital and now I'm being seen at a different hospital. And these doctors still collaborate on my care, which I find to be both outside of standard and also very interesting to a lot of the PH community because I know that's not always common. For example, when I was having a lot of side effects and a lot of symptoms, I went in for a heart cath and the numbers were not ideal. And I was pretty upset. And M said, "Hey, let's call H." And we did. And we called him on my cell phone. He picked up and we had a full 3-way team meeting in the room like that minute about what they both felt like the numbers were saying to them. And I think that it's so impressive from a patient standpoint that M is so humble and does not have a problem going and asking somebody else for their opinion because he wants to make sure he's doing right by me. And H has his own patients and is in his own state and does not technically see me anymore, but also has the ability to sit down and say, here is what I think. And he does that because he does care about me. And there are doctors out there who can care about you in that capacity. And it's so cool, I guess, to see it from a patient perspective that both of these doctors can give a crap at the end of the day.
I think first you have to realize that no man is an island, right? Part of our clinical practice is that we work as a team. Myself, Dr. B, he was my mentor. I trained under Dr. B. We have discussed a lot of different cases, and there's still days that go by where I'm uncertain of what I should do, or I need that sort of assurance that what I'm doing is the right thing. And we still discuss it with our colleagues. I think I've told you before, Gerry, that I don't think that any physician should be upset about a patient requesting a second opinion. I believe that you should have the right as a patient to get other opinions about your care and to see if they match up. I work in a big hospital, but that doesn't mean that I'm always correct. That doesn't mean that there won't be competing ideas, and that doesn't also mean that there can't be two different like pathways in your care to get ultimately to the same goal that you have. Being open in terms of communication, calling outside physicians that have referred patients to me, that's basically part of my practice. It's one thing as a consulting physician and provider to send a note back, but it's a different level of care. When I pick up the telephone and I actually call these referring physicians and say, hey, let's take 10 minutes and actually talk about your patient.
100% agree. It's very important when you're dealing with rare disease, especially that there are fewer treatment teams available in the country that know what's going on and know how to manage these things, but we cannot always be readily available to where our patients actually live. And in some parts of the country, there are more condensed amounts of those treatment groups than others. And so it can be easier for people to get access in on a regular basis. And there are sometimes people or patients will live farther away from the opportunity to engage on a regular basis. And so in that situation, you need to be able to find somebody who's going to be a champion, somebody who's going to partner with you that may not have the same medical expertise that we do on a rare disease, but have the ability and more than anything, have the primary focus of wanting to provide excellent care and take ownership of who that patient is and wanting to make sure that patient's well-being is the most important thing up front. And so if you have that, then you have the ability to be able to work in a situation and provide collaborative care in those situations, even when it's a situation like this, where you are states away. Dr. Moss is clearly your prescribing medical doctor. I have no ability to be able to do that in the state of Florida, nor do I claim to do that. But we can have conversation about what's going on with your story because I've been so intimately involved with your numbers and your case and everything that's happened. And so we can talk about similar things because of the fact of how well we both know you as a patient and know where you started and where you're going from. And that helps him then inform the decisions that you guys make together as far as your care.
It's interesting because I feel like I am always told that my story or my care is outside of what the standard is. And I do understand that this relationship, the three of us, is very different than a lot of patient stories. And I want to make sure that I tell the patients that are listening to this, you can find doctors out there that do care about you and do ask about your family and do just want to catch up with you when you're in their patient room. It's not always going to be a doctor that comes in and doesn't even know your name until he looks at your chart. I feel like, especially in the rare disease space and especially in the PH space, there is so much room for more time, like more time to be had, because when you are in that room, they don't always see PH patients. I know Moss sees asthma patients and other lung disease patients, and it's not always just a PAH patient. And so because of that, I think that if you have a rare disease and you are looking for a doctor, your story probably stands out anyway, because you are a rare disease and they probably don't only treat that rare disease. They probably treat multiple diseases. And so when I am sitting down with a doctor in any capacity, in my general doctor, my urgent care doctor, like I do sit and chat with them for a little bit, because I think from a patient perspective, you also forget that you guys are humans and that you guys also have your own families and you have your own lives. And I know your wives' names, I know your kids' names. I have also invested in you the way you have invested in me. And so a relationship doesn't work if you are the only person sharing and you're not asking questions too. And so I do want to say that if you do not feel like you have a relationship with your doctor, I would also say you probably should look inwardly and say, am I making room for a relationship, or am I just being the dictator and am I the only person having the conversation? Because at the end of the day, they don't want to get to know you if you're also not asking about their own lives.
I do think that's very important. I think the most important aspect of any doctor-patient relationship is trust, right? And obviously there is a trust in a patient wanting to trust that the doctor knows what they're talking about and has the expertise to be able to help them with a problem. But there's also the trust that needs to be developed that the doctor actually cares about them, the patient as a person, cares about who they are, what they're doing, how this disease state is impacting their life, their families' lives, their futures, those types of things. And again, it goes beyond the commitment of you're coming in, I'm writing you a prescription, you're going away, I'll see you next time. And so that part of it is true. But as you said, Gerry, it's very important that, again, as you're developing this relationship, a relationship is a two-way street, and that there is interest on both sides as far as getting to know things about the other person and wanting to show that there is value on both sides as far as who we are and providing things for you, but who you guys are as far as coming in and understanding our team, understanding our staff, understanding how we all work hard behind the scenes to make things happen. And like you said, that we are people that get to travel and do things and have good and bad days just like everybody else.
I certainly agree with everything that like Peter is actually saying. I think part of it though is that in terms of you, Gerry, you are an advocate for a rare disease. Okay. So you have an audience that obviously watches and you get to share your story. While this is a rare disease, your story is not necessarily unique. I have hundreds of patients who have very similar stories, hundreds of patients who are on fairly similar treatment regimens that you're on, and they have outcomes that are very similar to yours. But I always tell all of my patients, now that you are actually seeing us and you have a rare disease, you're going to have regular visits. And I tell them, you are now part of our dysfunctional family. And I say that jokingly. All of us have our own personalities. We have our quirks. I'm more introverted. I like to be more quiet, but we have to be able to establish a relationship with our patients. We have to know who they are. We have to know what their goals in life are because we want to help them to achieve those goals. But at the same time, these are people that I'm going to see back every 3 months or every 6 months. And I was very amazed when I first started in PH that Dr. B is able to recall the story of all of these patients off the top of his head. And I always thought, how does he do that? But guess what? I have a fellow right now and I can do that. All of the PH patients that I had or originally diagnosed or done an evaluation on, and I'm seeing back every 3 months, 4 months, 6 months. I've gotten to know their story, and I could tell you about what drugs they're on, what we've done, what their outcome has been. I could probably tell you about their occupations, what their spouse does, or what their name is. And that's just part of being in the PH community. That's part of taking care of a small subset of patients who have a rare life-threatening disease process, and they become your family because you're invested in their care the same way that, we are invested in your care.
I do feel like that's not every doctor though. And so I do dote on both of you because you do actually do those things and those are things that you are able to recall. But I have also been in the space where the doctor didn't know my name until he walked into the room. You know what I'm saying? And then it's, yes, there are doctors like you and Dr. B. There's doctors like H and his Dr. B's, and they all have the ability to listen and know and remember things. But there are so many doctors that are not like that and do not do that. And it's so unfortunate, right? Is that you guys operate in this space and in this capacity at such a high level. And there are so many doctors that don't do that. So I would love for you guys to give advice for the residents or the medical professionals that are listening in how to be able to do that.
I think part of it is the environment that we work in, right? I work at an accredited pulmonary hypertension comprehensive care center. We have to basically follow national guidelines as set forth by PHA. We make sure because we're in a rare disease space that we have appropriate time every visit. I see a limited number of patients daily. I have an hour for new consults and new evaluations, and I get half an hour for return visits. In that time, there is often time to talk about different things, but you have to also keep in mind that the patient is not just a heart cath number. They're not just an echo. They're not just lab work. This is a patient who is scared, a patient who is worried, a patient who has gone on Google and has read that the average life expectancy for a person who has PH who is not treated is around 3 to 5 years. and they're very nervous and they're very scared, and they're very scared that they're going to die early. So I think it's important to take that time to have a thorough understanding of where the patient is, what their fears are, and then to be honest. Gerry probably knows this, but I don't sugarcoat things. If the heart cath numbers don't look good, we're going to have that discussion. And you know that we've had that discussion before early in your diagnosis, but we're going to appropriately be worried when you're worried, and we're going to have a treatment plan in place, and then we're going to institute it. And hopefully, just like you did, you're going to get better. But it's important that you have open lines of communication. It's important that you tell patients the truth about their disease. And it's important that you have open lines of communication, especially for providers. I think it's probably hard in private practice when you have 30 patients on your schedule each day and you're in and out the door in 10 minutes. I don't think I would be the same physician that I am today if I had a schedule like that. I would be a nervous wreck and I would be afraid that I was missing things all the time. So I think it's inherent in our schedule that we just have more time. But I do think that there are patients who are going to take more time out of your day. And there's patients who I have an hour-long time slot for that I'm in and out in 15 minutes. So it just depends on the complexity, and you have to be fluid to adjust your day, and you have to maintain open lines of communication, and you have to basically making sure that you communicate with all parties.
I think that's great, John. I would add to that, going back to the underlying reason why somebody went into medicine in the first place, right? And all of us probably have different reasons, but hopefully a lot of it is wanting to take care of people and to make people better. For me, that foundation comes from my faith. But ultimately, when I walk in the room, I want to remember that the person on the other side of the table has a story, has had a journey, has had a situation, and it is a privilege for me to be able to step into that situation and to close the door and to have them talk about things that they wouldn't necessarily talk about with anybody else, and to really dive deep into a situation where they are probably coming with it, just like John said, the Google list of all the things that they found about pulmonary hypertension, whether that matches with their story or not. And so it's our job to not treat this relationship like a contract, but to treat this relationship in a way where we see the privilege and the opportunity to partner, to console and give support, to be real where we need to be real, to give hope to and optimism where we can, but also coming along exactly like John was saying, with the understanding of where are we at and where do we want to go and what options do we have to be able to get there. And if we're remembering that, remembering who the other person is on the side of the table, and again, that it is a privilege from our perspective to be a part of that, hopefully then that gives us the right heart posture as we're entering into the relationship and into the room to check ourselves at the door, check our ego at the door, check our personality or our prestige for whatever title we think we might have had or what we've earned at the door, to do it in a way of this is an individual person that deserves my best, my attention, my compassion right now.
I just love you guys. I love listening to you guys separately and then together, because it's so funny, because I do feel like you guys are so different. And one of the podcast episodes that I just recently did was about knowing your community and knowing who it is that you talk to for certain things. And there are obviously things that I go to each one of you about just separately, because I know what answers I'm looking for and what answers I'm going to get from you. If I'm looking for a direct response, I always ask Moss, because Moss is always like straight to the point. We don't sugarcoat anything. We don't fluff anything. And there is a lot of room for, I guess, when people receive that, it's different. And like, I love a direct person. I am very direct and I don't like to sugarcoat stuff. But also there are time and places where I am looking for something else. And so sometimes I will text H and just be like, listen, this is how I'm feeling. And he can speak to that from a level where he is also working in that space. So it is very different. But I do love listening to you guys together, because this is a great collaborative team because you guys are different. I think that if you guys were the same, it probably wouldn't work the way it works. I think that it works better because you guys are both very different. And so I love hearing both perspectives. And you guys can't see me on screen, but I was laughing when Moss said that I know that he doesn't sugarcoat, because he does not sugarcoat. But I do love that. And I know that there are a lot of patients that don't love that, but I personally love that. I respect a doctor that can just be like, this is what's up, and how do you want to address it, versus giving me the runaround and then telling me that it's bad 3 months down the road. So I think there's beauty in both sides of it. For the most part, I do feel like I am very fortunate to have doctors that will collaborate and will ding each other just to be like, hey, what do you think about this? Because that is something that I have seen to be very positive for my overall journey, my overall like health has been beneficial, because H and I talked about this clinical trial when I first started it. And Em and I talked about it too, but we talked about it in different capacities. And I think that it gave me a good round viewpoint of the subject, right? And so, same thing with treatment, same thing with going on pump. We each had a conversation about it, and it gave me a whole perspective instead of pieces of a perspective. So I think that it's very beneficial to have doctors that are willing to communicate and that are humble enough to communicate. And the way you guys both operate your practices, I think says a lot about who you are. And I think that I'm thankful for that. I'm thankful for both of you. And for the residents and the medical professionals that are doing this, that are listening, I just want you to know that if you feel like you have not done that to this point, like, you can still do that. And I think that there are ways that you can incorporate that, but then also have your own boundaries, because I know you guys are also human and you can only do so much. You're only stacked as much as your schedule says. And I get that. So I want to make sure that you all know that there is a way to do it for whichever practice that you're running.
And it's very true. I think the understanding, though, has to be even just that the things change and shift, and what role that we can play might change over time, right? So again, I got to be a part of the beginning of your story. I got to be a part of your story when you came back to Colorado and unfortunately had to come see us for some changes in your medical circumstances during one of those visits. But when you leave and go back to Florida and you're there in Florida, Dr. Moss is your doctor. And my role is to be a sounding board for what's going on in the situation to help support you as you process the information. My job is no longer to be the prescribing person. I'm not giving medical advice, but I have the role because I still care about you as a person, and you like having different people to be able to come to. And so I can provide that space and that support, as well as John and I have the ability to be able to talk about what's going on. If there are questions that he has, we can share and go back and forth on that information as he thinks about, and he makes the ultimate decision as far as what thinks is what's best for the situation. But I can provide a different way of support to still help you as you guys make that decision, even though I'm not the one that's actually giving the medical care. And the only reason that I'm doing that is because of how invested I've been in your story, in your journey, in your family, and in my patients in general, and wanting to make sure what that looks like. The vast majority of patients, when they pick up and move, and I think Dr. Moss would say this, we get them established somewhere. Maybe we get a phone call or two or an email or two. They get established, and then we don't hear a whole lot down the road. Maybe we'll run into them at a PHPN conference or something else, but they've established, and we get that and understand, and we're thankful for the time. But there are other situations where patients still value that relationship and value the trust that's been there and want that a part of their story going forward. And so we can change the relationship a little bit, but still be able to provide support, even if it's not the same type of relationship that we had when you were within the four borders of Colorado and I was your primary doctor.
I agree with everything. Peter says that sort of one of his motivational things is his faith. And I know that you've talked to me about that before, and you say, Dr. Moss doesn't express that outright. You're right. I was raised in a different sort of community than you were. I was raised Catholic, and I do believe in God and I do have faith, but I don't choose to talk about it that much. I let my actions show that. And one of my colleagues also says that I have a lot of Catholic guilt. So, when things don't go the right way, or if I say something that I regret, I feel really bad for it, and I have to get my atonement for that and go to confession for that. No, I do think it's important in how we treat people. I do think it's important that when a physician goes into a patient's room, that they actually listen. One of my biggest pet peeves is walking into a physician's office and they don't make eye contact with you. They look at the computer screen. So what I do is I basically ignore the computer for the first half of all of my visits. I walk in, I face the patient, we have a face-to-face conversation. They tell us what their symptoms are. We have a discussion back and forth, and there's not a lot of looking at objective data. Now, thankfully, we started using an AI software now that actually listens to our conversations and it writes all of our documentation actually for us. So I don't even have to take notes anymore. I can just listen, we can communicate. And I think that goes a long way because if you have a physician that seems invested in your story, a physician that actually listens to you, that rapport and that empathy shines through, when people are going to actually trust you more. So I think that's also a very important part of what we do.
I love you guys. I do feel like the reason that our relationship works so well is because you both make me feel safe. You both make me feel heard and seen. And those are really important things when it comes to any relationship, but especially patient-doctor relationships. I am so thankful that this is what my story looks like. And I feel so badly for people who feel like that is not what their relationship with their specialist is. I do know that there are tons of patients out there that have the exact same relationships that I have with you guys, with their doctors. And I'm so excited for you if that is what you have. But if you do not have that, I do pray that you find a doctor that you can relate with. I pray that you find a doctor that you can, I don't know, feel safe with, because that at the end of the day is the most important part for me, because this is my life, because this treatment, all of these doctor's appointments, all of this time spent is essentially just so that I can live the rest of this life out. I hope that you find that if you are not, if you have not found it. And I hope that this episode was good for you. I hope that you got to get a little bit of insight as to what my relationship with these doctors look like. I know that if you follow me on Instagram or TikTok, you've seen both of these guys all over my page. Now you just get to listen to our conversations just a little bit and to see how it sounds.
I'm still laughing that you still call us H&M, despite the fact that we actually said our names in the beginning of this podcast.
Name. It's a loved nickname. You get a nickname because I love you. Not everybody gets a nickname. If you want me to call you Moss all the time, you let me know.
I'm good with what you call me. It's better than other nicknames I've had.
If you loved this podcast, please like it, subscribe, and share it with your friends and family. Both of these guys will be back on for different episodes. But in the meantime, catch you guys later.